Hello, everyone.
I'm glad everyone could find this room. This is our second out of three of the renal room conferences for the year. I can't remember how the decision was made to move it here. I think it's because we were overflow upstairs. Now it feels empty and everyone feels far away. But we'll just try to make it interactive and good and feel closer than it looks right now. Lisa Davis, who's the sort of the co-organizer of this, is sick and wasn't able to come today. But we do have two great cases. And so maybe without any further ado, we'll just jump right in. And if people straggle in, then hopefully they'll be able to catch up. Um, do we have to worry about people on Zoom hearing? Does anyone know? Or okay. All right. Then great. Asim's going to take the first case. And you want to just give a quick intro to yourself for the renal folks who don't know you?
Hi, everyone. Thank you so much, Dr. Thurman. My name is Asim Mohammed, and I'm one of the second-year fellows at rheumatology. I probably dealt with a lot of you over texts and messages. Thank you so much for all your help, and thanks for everything you do for our patients. Without further delay, we're going to go presenting this case that we had at Denver Health. Very nice lady. And cheers to Dr. Davis. Hope she feels well soon. So we are dealing with a 27-year-old female with no significant past medical history, except some rashes and arthralgias in the past, who presented to the hospital with a progressive bilateral lower leg swelling for 3 weeks. And lower leg swelling was an underestimated of this lady's huge legs. For the last 3 weeks, she noted progressive fatigue associated with puffiness of the face around the eyes in the morning, worsening lower leg swelling, also noted some very dark urine. And she then developed dyspnea on exertion with walk-in 30 feet and also orthopnea. Her review system was largely negative. Like past medical history, she has some questionable RA diagnosis 4 years ago or something. Then she lost the follow-up, unfortunately, like a lot of our very keen patients. Arthralgia since 2021. Social history, she was born in Mexico, migrated years ago. She had positive cannabis use, denied any other alcohol, tobacco, or illicit drug use. Her mother had myasthenia gravis and had asthma, and her mother had and grandmother had lung cancer. Her vital signs were largely stable other than a prominently elevated blood pressure of 171 over 112. She appeared well generally with no findings on cardiovascular exam or HENT, but the musculoskeletal exam showed this profound 3+ lower extremity edema on both lower legs to above knees. She did not have any synovitis on exam of the joints, and her skin was warm and dry with prominently no skin rashes and no purpura or petechia. Her workup started with a chest X-ray that was consistent with more like a fluid overload and heart failure and large cardiac silhouette. Her renal ultrasound showed some increased cortical echogenicity, but very mild fullness to the kidney hole, but nothing prominent hydro. Her echo showed a grade 3 restrictive diastolic dysfunction. Left atrium was severely dilated, and then she had this mild, tiny pericardial effusion. Cardiac MRI also followed through that showed only small pericardial effusion, but otherwise unremarkable for any infiltrative process or any specific findings. And then here's a big, I put this view because I know our renal colleagues like to the trends. Believe it or not, none of our faculty actually look at this view. I don't know if anyone would raise hands, but they all look at certain tests. So, and the cheat sheet at the bottom here. So we noticed generally her complete blood count was very prominent for just a moderate normocytic anemia. Initially, she had leukopenia of a 3.1 dropped to 1.6 total with a differential of neutropenia and lymphopenia. Whenever we see lymphopenia in our patients, we think lupus. That's kind of what we think as rheumatologists. She had the 1+ schistocyte with that anemia, but then her hemolysis labs was largely negative with normal haptoglobin and LDH. No evidence of hemolysis. She had the prominent elevated inflammatory markers of ESR79. Funnily, in presentation, her CRP was normal and then spiked to 94 in patient. And then a busier slide, and for the renal folks, on your right over there is the urine, and at the bottom is the urine chemistry. And the cheat sheet also says, so she had acute kidney injury of a creatinine of 1.49. At a baseline a year ago was 0.6. And then through the hospitalization, that creatinine creeped up to 1.7. She has hyper K of a potassium of 6.3, non-onion gap metabolic acidosis. She had hypocalcemia, but then that corrected to the albumin of almost normal. Given her elevated ESR, her SPEP only showed a polyclonal gammopathy and hypoalbuminemia. Both kind of consistent with acute phase reactants, but the hypoalbuminemia with the renal failure makes us think about other differentials. And that's a key that we get on most of our patients with ESR to try to see, are we dealing with a generally inflammatory disorder when we see this polyclonal GAM. Her lipid panel was, for a young lady in her 20s, said hypertriglyceridemia, high LDL, and low HDL. And then we come to the urine. Her urine showed RBCs. Initial sample actually did not have red blood cells, but then showed RBCs, white cells, hyaline and granular, and WBC casts. And she had a lot of proteinuria that went up to 11.6. The total protein in urine was 4 gram and went up to 10.2 grams during the hospitalization. Her FINA, and I'm not sure if we actually still use these. I used to do it when I was a hospitalist, but it was a 2.6, and how we calculated between 2.6 to 3.7, indicating an intrinsic renal injury. So putting it together, acute kidney injury, hypertriglyceridemia, low albumin, and edema, she met for nephrotic syndrome. And some nephritic component with a hematuria and acute kidney injury. And here is our immunology. We usually call this rainbow, and when we see it, she had a positive ANA of 1 to 1280. Sorry about that. And positive chromatin antibody, positive dsDNA, both by ELISA and Critidia with significant titers. Smith antibody positives and Smith RMP. When we see positive Smith/RMP, we try to differentiate it. So we either send out for a Smith, and that was the positive component. She has positive SSA, both 52 and 60 kilodaltons, positive SSB, positive rheumatoid factor of a significant titer, ANCA negative, but positive MPO. And she had a low C3/17 and low C4 undetectable. And I want you to focus on the low complements here, because low complements are going to be crucial in differentiating our case. And we see the most prominent C4 drop more than the C3 in this case. Then she had positive cryos on 2 tests, which is luckily to get Endeavor Health. We get Endeavor Health, unfortunately, we get a lot of false negative cryos. And then whenever you get a positive cryo, you want to know what type of cryo you're dealing with. So the immunofluorescence for that showed a monoclonal IgG lambda, so mono, and a polyclonal IgG kappa. Mono to poly, that's a type 2 cryos. And I hate cryos with passion. And that's why I use a talk today to kind of try to simplify that from my own memory and for people to register it.
There, look back, several, why check any beyond double-stranded DNA? It's Smith chromosomes. Oh,
Very good. So how we been getting the testing lately? We've been using ANA with reflex, and whenever the ANA is positive with a significant titer, it reflexes to all these together. So since I started practicing in rheumatology, I haven't ordered those separately. So I get an ANA, and if it's positive, it will reflex most of the time to double-stranded DNA, Smith, SSA, SSB, SCL70, JO1 sometimes, and the chromatin. We see, I mean, you try to get more evidence of what disease you're dealing with. And if you get a positive dsDNA, that's more towards lupus, but sometimes it's falsely positive in like hematological malignancies. So once you get the Smith with it, that's a very more strong evidence that this is more lupusy pathology. And if you have those two, and then you develop SSA or SSB, a lot of the times those are just co-antibodies. They do not indicate a separate Sjogren, but they're also seen in lupus in concomitant with the dsDNA and Smith. Chromatin is seen in lupus. I don't see us using it a lot by itself. But a lot of the times when I see a dsDNA and Smith, the rest of it is kind of more like lupus. And technically, that's what you put that on your clinical picture, your cytopenias and your complementemia to say, okay, I'm dealing with lupus. But that's all right. Let's just scroll to that real quick. Please repeat the question for those of us on Zoom. Sorry. Yeah, Dr. Thurman here asked me, why would we usually test all these antibodies together? And why, since we already have a positive dsDNA, why we test for the rest of them? And I kind of replied by Most of it just reflex, and then we try to deal with which one is the primary antibody, and then which ones are just secondary for the disorder that we're dealing with. Thank you. I was not in the hospital that day, and the description on the notes, I didn't see rash actually. Oh, she did? Yeah, sorry about that. Yeah, I just didn't see it in documentation. And I might hear from you guys. So she had a rash described. Got it. Here, yeah, here. I was not the one who saw this patient inpatient, and Dr. Colfan back here just mentioned that the patient actually had lower extremity rash, looks like LCV, and that was questionable whether it was the first or the second hospitalization when that rash was noted and triggered the workup for cryos. All right. So eventually, she ended up getting a renal biopsy, and that showed the diffuse lupus nephritis of a class 4 in context of the clinical lupus nephritis with a NIH activity index of 13/24, NIH chronicity of 3/12, focal moderate to severe arteriosclerosis, no global glomerulosclerosis, mild interstitial fibrosis with tubular atrophy, a lot of markers of chronic damage. But then she had this finding that's called haline pseudothrombi compatible with cryoglobulin. And this is the first time I see this comment, and I think this is an image of it. And it's basically just simply, it is more of a cryo precipitates into the capillaries of the renal glomeruli. I've seen those described in multiple case reports between Sjogren syndrome, monoclonal gammopathies, and MGUS, and they all are more due to cryos precipitating in the capillaries. And I'll leave the pathology more to Manny. He's going to be talking in details about pathology. So we're gonna, from this point here, we're gonna take a quick dive into what's going on with our patient. We're dealing with lupus and cryoglobulinemia coexisted together. That's not very uncommon to see. So we're gonna, and I hate cryos with passion. So we're gonna quickly try to simplify what are we dealing with, how do we study cryos, and how do we look at cryos here before we go into the treatment course. So in 1947, Lerner and Watson coined the term cryoglobulins. It applies to immunoglobulin that can precipitate in vitro from plasma or serum with the temperature falls below 37 and then resolubilize when warming. So these cryos are as proteins that precipitate when it's cold and then solubilize again when it's warm. And he divided it into type 1, type 2, and then type 3. And this is very complicated for me, but I want you to think about cryos. And this is more like fellow level, MP level. We all, when we're dealing with this, I want you to think about cryos as as proteins that is formed by the body against another protein that is formed in an abnormal disorder. And you'll see about all this mono to poly, mono to mono, mono to poly. And how we look at it is type 1 cryo is mono to mono, so 1 to 1. So it happens in the disorders that forms a monoclonal antibody. So your body has myeloma, and then you develop this monoclonal antibody. Then your body reacts by forming a monoclonal protein against that monoclonal antibody. And that's why type 1 is 1 to 1 to 1 in processes that has only one protein. And that's why we see it in lymphoproliferative disorders and monoclonal gammopathies, multiple myeloma, MGUS, CLL, non-Hodgkin lymphoma. Then you come to type 2, and that's just spreads it out a little bit, is also your body also forms only one monoclonal IgM cryo against the disorders that had poly-IgG or polyclonal gammopathy. When do we see monoclonal gammopathy? Autoimmune disorders and infections. So that's type 2. Your body forms this polyclonal gammopathy for any inflammatory infectious disorder, and then the cryos form by forming one antibody monoclonal against those polys. So that's type 2. To make it more complicated, you go to type 3, is when your body's like sick of it, and I'm done. All right. So you have a disorder that has polyclonal gammopathy, and then your body forms a polyclonal IgM that just precipitate all these. And that's what type 3 is. And you see the similarity here is more between type 2 and type 3, and they both together are just called mixed cryoglobulins. And those are the ones we deal with in rheumatology, because most of our disorders form polyclonal gammopathy, and then the body reacts by forming either a monoclonal IgM to it or a polyclonal IgM to it. So that's mixed cryoglobulinemia. That's the one we deal with. Actually, both and mostly in rheumatology because our disorders form polyclonal gammopathy, and in nephrology because the mixed cryos are the ones that attack the kidney the most. Period. Our colleague hematologists can be happy and take care of type 1 the way they want. So most of the causes are more like infections. Hep C is most common. Other viruses or infections like Hep B, CMV, EBV, parvovirus, B19, HIV, pyrogenic bacteria infection, candidiasis, Coxiella, leishmaniasis, autoimmune diseases, including lupus, Sjogren, and if you have that overlap syndrome between cryos and another autoimmune disease, that usually leads to a lot of severe vasculopathy, like non-healing ulcers and gangrenes, lymphoproliferative disorders, that can cause it, as we said, is large B-cell lymphoma, non-Hodgkin lymphoma. 30 to 50% of patients with Hep C actually have serum cryos, but only 1/3 develop cryoglobulinic syndrome. So again, we mentioned type 1, monoclonal to monoclonal, and those ones usually present with hyperviscosity syndromes, and mainly in like vasculitis, like in the skin, with Raynaud's, ulcers, gangrene, and rarely involve the kidney. Then we come to our lump sum favorite, type 2 and type 3, mixed cryoglobulins. Those are asymptomatic most of the time, but can cause skin, musculoskeletal, and kidneys. Those are the three organs you think about, plus or minus CNS. And that's through activating the FC receptor of macrophages. And if we come to the manifestations here of cryos, when you're looking at a patient, you think about skin, you have palpable purpura in the dependent areas, digital ulcers, or gangrene. Musculoskeletal, and that's kind of good to know, it causes arthralgia, but not arthritis. So we don't see synovitis or inflammation unless there is an underlying rheumatoid arthritis or lupus or so. So just a lot of pain in the hands and knees. And then neurologically, it will commonly cause a bilateral and symmetrical distal sensory motor neuropathy or sensory neuropathy. And renal involvement generally indicates a poor prognosis, hematuria, proteinuria, and worsening renal function. Rare manifestations can go all the way to CNS vasculitis, hemiplegia, coma, encephalopathy, or seizures, GI like mesenteric vasculitis, duodenal vasculitis, and pancreatitis. It can cause DAH with pulmonary hemorrhage, rarely hemoptysis, dyspnea, etc. It can also cause hypertrophic cardiomyopathy with dyspnea on exertion, pericarditis, or coronary artery vasculitis and heart failure, hyperviscosity syndromes. Interestingly, cryoglobulins by itself cause a lot of dry eyes, dry mouth, Sjogren-like syndrome, and it can cause parotitis because of that salivary gland inflammation. So this is kind of quick overview. Again, just think about the joints, the musculoskeletal system, and the kidney. And that's usually dealing with mixed cryoglobulins. As we said, in most the glomerular cryoglobulinemia, glomerulonephritis, and here I hope I'm not stealing your thunder. I'm just going to go brief. I'm not going to talk about pathology. Most commonly, it occurs in the setting of type 2, mixed. So all you need to walk out with today is type 2 and type 3, or mixed are ours. Type 1 is mono for all the monoclonal disorders. Most patients with type 2 and type 3 globulin have positive rheumatoid factor. And that's a very good way to know about it because they have these proteins that have rheumatoid factor like pathology. Novel antivirals may be effective in treating Hep C virus and associated cryoglobulinemia with beneficial effects on the kidney disease. But however, mortality if the glomerulonephritis develop is still high with 50% 10-year survival in those with mixed cryos and decreased kidney function at presentation. Cryoglobulinemia glomerulonephritis can recur in the transplant as well. Intracapillary walls, basically it gives, if you had to remember one thing as a rheumatologist, and sorry, with all due respect to nephrology, all I care about is membranoproliferative pattern of injury. And that's usually presented with nephrotic syndrome, if I remember okay from the boards, but please teach me something different afterwards. Patients have nephrotic and nephrotic syndromes with various levels of kidney function, purpura, and arthralgia, as we mentioned. And then you have abnormal serological studies. Low C4 is most prominent, is 3/4 of patients, and then low C3 in half. And all three types of cryos, the bottom line, including due to both monoclonal and polyclonal, can cause cryoglobulinemic glomerulonephritis, but way less in type 1. Then SLE and cryos. Interestingly, cryos are very frequent in lupus, but mostly asymptomatic. 66% of lupus patients in this panel that they studied out of 215 patients we're going to come to next, 66% had cryos, but only 15% of the patient with lupus had develop cryoglomerular vasculitis. Features of cryovasculitis, again, involve the skin, joints, and general signs, and severe manifestations of vasculitis were very rare. And here's the panel. As we said, 66%. Mostly they were type 3 in 80% and type 2 in 19%. Bottom line, it was mixed cryos, and the mean concentration was 40 milligrams. Patient with cryos, significantly more C4 consumption, and mainly, as we said, they were cutaneous findings with ulcers, articular, without death on the follow-up. 67% of them still had persistent cryos on follow-up. And the severe manifestations in this panel was actually way less in kidney, with glomerulonephritis only in one patient, 5% of the panel, and CNS involvement in 4 patients, 19% of the patients. The good thing is response to first-line treatment was observed in 12 out of the 13 patients with a vasculitis, but relapse was observed in about 3 out of the 12, which is 25 patients. So how do we approach cryos? And as vague as it sounds, you start with general workup with CBC, renal function, UA, urine protein, and protein creatinine ratio, and a 24-hour urine protein, because you're looking for that nephrotic syndrome. And then you order the cryos. It is very notorious in most of the labs. It's very difficult. It has high false negative and also false positive because of the collection error. Because as we said, the blood should be drawn into a preheated tube at 37 centigrades until it coagulates. And then it should be followed by centrifugation, after which it should be stored at a 4 centigrade for 7 days. That will form a white precipitate and then indicate the presence of cryos at the bottom of the tube. So if you mess up this heating, reheating, cooling, you get a false sample because the cryos will be gone. Then quantification measures of percentage of cryos, so they will quantify them to see if they're significant or not. And after that, you need to characterize it by either immunological methods of immune fixation or immune diffusion to see what type of immunoglobulins are you dealing with.
So we all that just the good, like we forget about this whole past and just check rheumatoid factor and be down at T3.
And that's so as we said, rheumatoid factor is positive in the type 2 and type 3. And you need that combination of positive rheumatoid factor, low C4 predominantly, plus or minus C3, and a very typical presentation. So you can have a high classical suspicion. And unless I'm dealing with a full syndrome with C3GN and positive rheumatoid factor, I can say, okay, this is cryo, and I can treat as cryo if the suspicion is high and there's no other competing diagnosis. But is that enough for diagnosis alone? I'm not sure. But it's a poor man's cryo. And then to repeat testing increases the accuracy. So they try to do it once or twice. So, and then as Dr. Thurman mentioned, rheumatoid factor and complement should be tested in all patients suspected of having cryovasculitis. Rheumatoid factor positive, low C4, normal to mildly low C3. Other serologies are only dependent on the clinical presentation. So if you're thinking lupus, you test for lupus. Infections, Hep C virus actually should be tested on everybody. Hep C antibody and plus or minus RNA. And then Hep B serology can also be tested. And then malignancy, depending on the clinical situation. If you have an SPEP with a monoclonal or you have a lot of lymph nodes, etc., then you can go all the way, you get the SPEP and you can get all the way to bone marrow biopsy flow cytometry. And then if you have rash, you get a skin biopsy of the lesion and you send it for histopath and immunofluorescence because you want to see the precipitation. And if you have a renal involvement, that's when you go for renal biopsy. All right, treatment. And I think this is a very good part here. I'll try to go short, but this is just highlights. So if you have an acute rapid presentation like mesenteric vasculitis, diffuse alveolar hemorrhage, and rapidly progressive glomerulonephritis, plasmapheresis and high-dose steroids are the first line. And that's in acute, rapidly progressive. Please remember, IVIG is contraindicated. And that's because you have a lot of antibodies already and antibodies against antibodies, and you don't want to give antibodies against antibodies against antibodies because that's what will give you a clot. And so complex deposition and multi-organ failure. Rituximab or cyclophosphamide plus plasmapheresis plus steroids reduces the relapse. Antiretrovirals, Hep C, and this is the interesting point, is not the first line in the life-threatening cases. So if your patient is crashing, that's not the time to give him an antiviral. And the immunogenicity already propagated beyond that hep C infection. Then we come to our more like day-to-day milder cases, skin rash, ulcers, glomerulonephritis. These are more like not life-threatening immediately. That's the point when you think about steroids and rituximab. And that's, I think, about 90% of the cases we treat. And then most of them had good response with the resolution of symptoms 6 months after starting rituximab. The repeated courses of rituximab might be needed to maintain remission. Cyclophosphamide was also tried. Sjogren, lupus patients benefit from corticosteroids, and then immunosuppressants like cyclophosphamide in severe cases, methotrexate in milder cases, MMF in refractory cases were all used. Another very good highlight point here, TNF inhibitors are not used. They've been tried, they showed early relapses and occasional worsening of neuropathy and skin ulcers, so that's why we're not doing it. So all you have to remember is no IVIG and no TNF inhibitors. Again, antivirals for hep C, very important, not in the life-threatening phase. And then treatment of underlying malignancy like B-cell dyscrasias. And this is for the type 1 here. Cyclophosphamide, dexamethasone, and thalidomide can treat the skin and not the renal involvement. Again, luckily, type 1 does not affect the kidney much. And then there is this novel drug, bortezomib, successful in treating cryovasculitis related to multiple myeloma and MGUS, which is type 1, and then in concomitant cryovasculitis and cold agglutinin disease. Also used in rituximab-resistant cases. Plasmapheresis is done in life-threatening complications like renal failure and severe cutaneous disease. Hep B infection. When you're dealing with Hep B infection, you remember rituximab is dangerous. So antiviral therapy should ideally be done before, or at worst case scenario, concomitant with immune suppression and severe reactivation risk with rituximab. Other infections, if you're dealing with a cryo secondary to a bacterial infection, actually immune suppression is really not indicated. You treat the underlying infection, you follow the cryos unless they're life-threatening. You'd only use it if it's refractory. And here's a quick course of going back to our patient. She had a very rough, complicated course. We started treatment with solumidrol and prednisone, MMF, 3 grams, and Bactrim. And we planned, okay, you know how Denver Health, go home, get rituximab outpatient. For the cryos, she got readmitted right away with worsening proteinuria up to 10 grams, creatinine spiked at 2, pruritic diffuse skin rash on the back, chest, neck, fever. The skin biopsy at this point showed neutrophilic infiltrates with immunofluorescence with rainbow, IgG, IgM, and C3. The biopsy showed this is likely lupus, but she was already on high-dose steroids, mind you. She already was on MMF. But this resolved with discontinuing Bactrim and switched to bentamidine. So we assumed the diagnosis of a lupus sensitizing to Bactrim. And then she went home, successfully was sent to rituximab. From the infusion center, she got readmitted again. Unfortunately, this time with fevers, palmoplantar erythematous rash with vesicular lesions, bullous lupus was the clinical diagnosis. So we switched her to Dapsone because Dapsone treats bullous lupus and it treats, and that hospitalization she had some CMV viremia, but negative on the swabs. And she had this 1 after 2 swabs that has herpes simplex. So they also gave her acyclovir. She was discharged home. She finally started rituximab, and eventually creatinine started improving, and it actually normalized at this point. But protein is still persistently elevated at 8.4. She still has high lupus serology and low complements, and she finally just received the second dose of rituximab yesterday. We're looking forward to see her in clinic. That's that for me. Any questions? Dr. Dean?
Actually,
I have a yeah.
Understood. No dates on the slides.
Can I ask why she was not treated with plasmapheresis since this is RPGN?
Zoom question. Again, we couldn't hear you.
So sorry. Why was she not treated with plasmapheresis since she had RPGN?
Yeah, that is so. I'm not sure. The plasmapheresis usually they describe it as if it's rapidly progressive nephritis. I'm not sure if that's synonymous, and I would allow maybe Manu can tell us more whether membranous proliferative glomerulonephritis alone is an indication of life-threatening, or that's more of a glomerulonephritis that we can treat.
Well, I think it is life-threatening. I mean, her symptoms are only 3 weeks, and your creatinine is already pretty high.
Correct. Correct. I'm not sure the answer to that question or what was the rationale of the treating team at that point. But yeah, she did not receive plasmapheresis. And Dr. Dean asked a question about no dates. Yeah.
No, in what? The world. But
Yeah, that she had that positive serology, she had arthralgias, and she had all these rashes back and forth. She make it complicated with lose the follow-up, and then her diagnosis was a question of rheumatoid arthritis with positive ANA at that point, is what I got in the chart. But then she never followed with anybody. Absolutely. Absolutely. Any last questions? Got it. I'll leave that to you to talk about the role of ACE inhibitors with MPGN. Is that okay? Absolutely. Got it. I mean, it's the case is only 2 months old, so she's still in that phase of barely normalize her creatinine at this point. So yes, I'm not sure if she enrolled in any study. Yes, please, at the back.
they noticed they would lack comment about part. That's subtle point. Fixate to go drop by the peak not active. Two low dose steroid was that's there's no data suggests it tells what question. Well, yes, try like eyesight, sir.
Well, thank you so much. I'm not sure if that was related to Zoom people, but there was lack of cryoprecipitates in the kidney, and it was felt that her lupus was the main driver of her renal injury with a lot of tubular injury. That's why the ACE inhibitors were held initially. Well, thank you so much, and I'll pass the mic to Manu. Thank you guys so much.
All right. Thanks, Awesome. Thank you guys for joining us here today. So we've got a second case here. We're going to touch on some of the things that Awesome's touched on, but we're going to take the case in a slightly different angle. Please feel free to ask any questions or comments throughout the presentation. So we're going to start off. I know we got rheumatologists here and nephrologists, but for a second, we're going to imagine we're all nephrologists. We got a 20-year-old female that's referred to your clinic. Not a lot of significant past medical history. She's recently been diagnosed with hypertension. She has class 3 obesity, but besides that, no medical history prior to the hypertension diagnosis. And the concern that the PCP is having is that she has very abnormal urinalysis. They note that she's been persistently proteinuric, has hematuria and pyuria. They actually went ahead and quantified her proteinuria, and she had over 10 grams of protein on a UPCR. And then on review of the renal function panel, it turns out her creatinine's up to 1.9, again, in a 20-year-old female, whose creatinine a year prior was 0.9. So the things that PCP has done before you see the patient is they've obtained an albumin level that's oscillated between 2.7 and 3.2, and then they've obtained complement levels, which are low here in this pattern. For the rheumatologist, there's no arthralgias, there's no rashes that are identified. For the nephrologist, the kidney ultrasound shows 13 centimeter kidneys bilaterally. Not a lot of changes, okay? Medication-wise, she's just currently on lisinopril and Adderall. I forgot to mention she also has a history of ADHD. So this is real life. Sometimes you get this patient with no other labs and they're in your clinic, and you got to have some thoughts here. So can one of the nephrology fellows kind of kind of give us a synopsis of what they're seeing here and their initial thoughts if they were taking care of a patient like this in clinic? A fellow named Marco, maybe. Any initial thoughts?
Keep up conference.
Mhm.
Yeah.
Sweet, yeah. So this definitely has kind of the sense of um some that maybe renal room overlap for sure. But one of the things I think I want to call our attention to is, Austin kind of pointed out this a little while ago. When you see this significant kind of discrepancy in complements, this isn't a completely sensitive or specific finding, but when you see a disproportionately low C4 from a C3, it should tip your head to the consideration of a certain something. Anybody have any thoughts? Great cryos, right? But another thing that you might think about as a nephrologist, kind of a broader category, which is MPGN. Okay, we tend to see this often. Cryo can definitely do this. Um, but what I'm hearing from Marco is that she's young and we're worried, right? These are concerning findings in a young female, and so there's not a lot of time to dilly dally. Obviously, you're going to send off a pretty complete serologic workup, but I think it's also reasonable for this patient to move forward towards a biopsy pretty early, and that's what was done in this case. And so instead of giving you any labs, I'm going to torture you with some path instead. Um, so for our room colleagues, what you see here, you guys can see my cursor. On the left is a normal glomerulus. And what we see here, this kind of purple staining area is mesangium. And when we look here, these open circles are your capillary loops. And what you can see is the mesangium is kind of small, not really expanded, not a lot of cells within it. When you look at the capillary loops, they've got thin walls. And although you see a couple cells there within the capillary loops, they're pretty open, right? Everybody can agree to that. Let's contrast that with our patient's glomerulus over here on the right. And you can see that this mesangial area now has expanded and has significantly more uh, cellular infiltration, right? So you would call this mesangial hypercellularity there. And when you look at the capillary loops, some of them actually look closed because of the preponderance of cells that you see within them. And then if you look closely here, right, in normal, you have these thin capillary loops, but let's look at her capillary loops. See how they're thickened? You guys can see how thickened they are kind of throughout there. Okay. So obviously a lot of these findings feel abnormal. We don't see, for those of us that don't look at this that often, kind of hard to tease out the differences, but you can tell that there's some pathology here that's concerning. This isn't our patient's biopsy, but we can imagine. What you see here is within the intercapillary loops, you see these areas that look kind of like clots. This is a PAS stain. It's positive here, but these clots kind of have this glassy looking appearance. And a pathologist might call this an intracapillary protein thrombi. Some old school pathologists might call this pseudothrombi. And when you look at the patient's H&E, again, what you see is that these capillary loops, the walls are kind of thickened. Some of them are starting to close off. And then overall, the glomerulus has this kind of lobulated appearance to it. Kind of nodular would be another way to describe it. And when we look at the last stain here, which is the silver stain, this is a stain that helps us analyze the glomerular basement membrane a little bit better. So we might look at the glomerular basement membrane and look for things that we call spikes and holes that would be suggestive of like subepithelial deposits in the setting of membranous. We don't see that here, but what we do see, guys, is this reduplication of the glomerular basement membrane. And there's concern that it actually looks like the mesangium is starting to create kind of sneak in to where that area has been in between the two pieces of the GBM there. This was also given the name of tram tracking appearance. Okay. So again, polynephrology fellow question. What pattern of injury would this be? It's a pattern of injury. It's not a diagnosis. I hear the mumbles. So I think this is probably, we'd all be in agreement of an MPGM pattern, right? And again, it's very useful. This is one of those diagnoses that on pathology, kind of has very characteristic findings, and we can get used to reading these words and identifying this, right? So when you hear that there's mesangial and endocapillary hypercellularity, you note in your path report that there's a presence of double contouring within the GBM. All these things should make you consider that this patient has an MPGN pattern of injury. And the reason I keep saying pattern of injury is that MPGN is not a diagnosis, right? I think sometimes we fall into the trap of talking about MPGN as if it's a diagnosis. We say, oh, one of the things I'm considering is MPGN for this patient. The truth is that's a pattern of injury on pathology, but it's our job as nephrologists to then take to the next step and try to define from that pattern of injury, what's a likely diagnosis, okay? And when I first started as a fellow, I really struggled with how to conceptualize this. And I found this that I think really underscores that it's not that tough to think about. If you have MPGN pattern on light microscopy, you can use immunofluorescence to help define your differential diagnosis. So if you have an MPGN pattern and your IF is negative for immunoglobulins, you're dealing with a complement mediated MPGN, and you really just got your C3 glomerulopathies there to consider. So dense deposit disease and C3GN. If you have MPGN pattern and you've got positive immunoglobulins and positive complements, instead now you're dealing with an immune complex form of MPGN, and you've really got three buckets: monoclonal gammopathies, autoimmune conditions, and infections. So circle back to our patient. And so you guys already did this because you're mini pathologists here with me, but we identified that the patient had nodular mesangial sclerosis, which we noted on the H&E. The glomeruli showed mesangial expansion with hypercellularity and endocapillary proliferation. There was prominent mesangial interpositioning and duplication of the GBM that we identified on the silver stain. There's no presence of crescents here, and they noted occasional intracapillary protein thrombi. On IF, this again is very helpful. We note that the patient has IgM 3+, IgG1+, C3 3+, C1q 3+, kappa lambda 3+. So we come back to here and we can say, because we have presence of immunoglobulins within IF, we're not dealing with the right side of this flowchart. We're dealing with an immune complex mediated form of MPGN. And we've narrowed our diagnosis to these three general buckets here. Again, this is a laundry list of things not worth remembering, but I think clinical context would help push you one way or the other, obviously. So let's come back to our patient. The thing that I didn't mention to you guys is the EM findings. So the EM shows subendothelial mesangial electron dense deposits that are present and are organized as a substructure of annular tubular arrays on higher magnification. Right? So I just said all those words. Any diagnosis? It's perfect. Any other thoughts? So the reason I wanted to bring this case up is kind of interesting. We're doing this backwards because in clinical practice, obviously we're going to look at the total picture, look at serologies, etc. But here you actually have a way of making a diagnosis straight off of pathology. And it turns out that what this patient has is cryoglobulonemic GN. And the findings for cryoglobulonemic GN are going to be the MPGN pattern on light. Occasionally, you can see these intracapillary protein thrombi, which are going to be PAS positive. The IF tends to have an IgM and C3 predominant picture, specifically in mixed cryos. And then these substructures within the mesangium, the subendothelium, tend to be typical for cryos. So when we mentioned endothelial deposits that we can see at higher magnifications on EM, that's something that we see more with cryos rather than just with lupus. And they can take on different kind of appearances here. So you've got tubular, fibrillar, crystalloid, and even fingerprint-like substructures that can be identified on EM. And for the nephrology folks, one of the things that kind of struck me is, well, how would you distinguish this between other things that would have substructures, right? So like amyloid or like fibrillary, et cetera, you can stain for those. And so if you stain for those and they're negative, then you're kind of left thinking that this might be more of a cryo picture. Something like immunotactoid is much larger than what you'd be seeing here. So Awesome already kind of touched on the classifications of cryo, so I'm not going to spend too much time there. But again, what we're mostly dealing with is going to be your mixed cryoglobulinemia. So I'll give you the serologies now. Again, this pretty healthy 20-year-old actually ends up having untreated hep C. Her cryos show what looks like a mixed pattern between IgG and IgM. Her ANA for you guys is negative. So the mechanism by which hepatitis C causes cryoglobulinemia is really interesting. So B cells and hepatocytes have a shared receptor, the CD81 receptor. Hep C can actually infect the B cell and kind of causes this proliferation of these polyclonal immunoglobulins to be produced, and that ends up causing end organ damage as they coalesce and form larger structures. So the patient is treated with Mavorite. Decision is made to initiate Ritux, given the AKI and proteinuria. So I have a question for you guys. We'll do hands. How many of you check IG levels before starting Ritux? Okay, so all the rheumatologists and Dr. Podol, perfect. And then at what level of IgG do you consider administration of IVIG or consultation with immunology for you guys that do check this?
So far, cool, but probably you could say if you have to go the 300, you feel serious. And if you have to go the 500-ish with the
Awesome. So Asim was saying no super strong rule, but if you're in the severe hypogammaglobulinemia range, you might be thinking about treatment at that point. Or even if you're not severe, you're moderate, but you're having recurrent infections, might be a consideration as well. Look at the chat, less than 500 with frequent infections. Good. All right. So this is our patient's IG levels. So you see IgG is less than 100. So this is pretty severe, right? The actual definition is just like Asim kind of alluded to, anywhere from 0 to 199 would be considered severe. 200 to 400 is moderate, and then 400 less than 600 I think would be mild. And so this patient has a severe hypogammaglobulinemia here that we identified. And for those of us that wouldn't have checked, that's okay. We just wouldn't have known, and that maybe would have been fine or maybe not. And we'll kind of dig through that data here in a second. Frequent infections would be a driver, KD Moore says. Okay. So one of the things that I was kind of considering when thinking about this is I was struggling a little bit to think through, how does rituximab cause you to become hypogammaglobulinemic? Because as we all know, Ritux is a CD20 monoclonal antibody, and when you see the plasma cells that are producing immunoglobulins don't have CD20. So what's the mechanism there driving the blunted immunoglobulin response over time? And kind of the postulated mechanism is that over time, you need these kind of earlier lineage cells to repopulate your plasma cells. And so if things like your pre-B cells, your immature B cells, et cetera, which are affected with rituximab, become depleted or non-functioning, the ability to repopulate these plasma cells that produce immunoglobulins becomes impaired. And so that, I think, is the most accepted kind of mechanism for why rituximab can contribute to hypogammaglobulinemia over time. So you guys are it's an interesting group, right? You guys are all on top of it. All our rheumatology colleagues are checking for this, but yeah.
5 block bots, hit bots. Gamma-globulin, part of that. That's the bigger life gets, right?
Yeah, I'll save that towards the end a little bit because immunology actually weighed in as to why they thought this patient had severe hypogammaglobulinemia. And this actually occurred, so this occurred at the time of the diagnosis, but their thought they attributed not so much to the cryo, but to something else I will mention here in a second. So it sounds like a good proportion of our group is actually checking for this, but what about what's going on like nationwide, right? So this was a study that looked at a very large healthcare organization. They had 4,479 patients who were going to receive rituximab, and they wanted to know what percentage of these patients had immunoglobulins checked before rituximab initiation. And you can see that 85% of the patients did not have immunoglobulin levels checked up front. This was a cohort that looked at cancer patients, rheumatologic disorders, primary immunodeficiencies, and then hematologic disorders as well. And after being initiated on rituximab, well, what percentage at that point ended up getting immunoglobulin levels checked? And again, 87.5% of patients did not ever have immunoglobulin levels checked at the 18-month mark. So, of those that were checked, we were able to glean a little bit of information here. You can see in panel A that if you started off with a normal IgG level, your chance of at 18 months developing severe hypogammaglobulinemia is pretty low. Whereas if you start with moderate hypogammaglobulinemia, 20% of the patients actually end up with severe hypogammaglobulinemia at the 18-month mark after receiving rituximab. Again, yeah, no, 0 to 200. Yeah. Yeah, and we'll look a little bit at like the symptomatic hypogammaglobulinemia patients and some other papers, but here was just using laboratory definitions. So, you know what this I think is getting at is if you start low, you might go lower. If you start normal, it's very unlikely you're going to fall into that severe range down the road, even if you received rituximab. So this again, paper kind of showing a similar thing. So this was primarily a vasculitis cohort with some lupus patients. And what they did, they wanted to kind of identify the association between your IgG concentration when you began rituximab and where you nadered your IgG concentration over time. And I think this was at 18 months as well. And you can see that there's an association. If you start with a lower IgG concentration prior to rituximab, you tend to end up staying at a pretty low IgG concentration over time. If you start off with a pretty high IgG concentration, you don't typically drop off your IgG concentration over time. The relationship kind of goes in the opposite direction there. And so, again, kind of making an argument for might be worthwhile to know where your patient stands up front to understand their infection risk, etc. This is a study that looked at a cohort of actually non-Hodgkin lymphoma patients. Not a lot of applicability for us, but I think there's still some things here that are worth looking at. So these are 211 patients that were treated with Ritux for 6 doses and follow-up was 3 years. And again, what we see is if you start off with kind of low IgG levels, you decrease further in 3/4 of the cases. But if you start off at normal, you decrease only about 40% of the time. So what they did in this paper is they decided to treat all symptomatic hypogammaglobulinemia, which was defined as 2 or more non-neutropenic infections with IVIG. And what you see is in this table on the left, you have 6 months prior to IVIG, on the right, 6 months after IVIG administration. And what you see in the cohort of patients is that infection rate went down from 30 to 16. So you halved infection risk with administration of IVIG in patients who had already proven symptomatic hypogammaglobulinemia. Because one of the questions I had is, yeah, we all think about IVIG. Is it actually beneficial? At least in this cohort of patients, it did decrease infection by half. So again, maybe this is a little bit more applicable to our patients. So this is primarily a vasculitis cohort with some lupus patients. And what we see here is they were trying to take a look at what was the effect of receiving rituximab on your Ig levels over the long term. And so this is kind of a cool graph here. So all the way on the left here, we see at 12 months from receiving rituximab, they basically stratified you as normal, mild, moderate, or severe hypogammaglobulinemia. And they wanted to see where did you end up at month 60. And you see that if you were within the moderate group, it was about a third, a third of a third. A third of the patients normalized, a third remained moderate, and a third, in the mild group, a third downtrended to more moderate hypogammaglobulinemia. But if you look at the severe patients, you see they don't really pick up too much. There's some splay of some patients who get better, but a lot of these patients don't, and a lot of them end up actually requiring immunoglobulin replacement. So I think the takeaway here is it's not consistent among all patients, but if you start off low, it's unlikely that you're going to get better, and it's higher likelihood that you're going to end up requiring IVIG. Again, trying to make an argument for knowing this upfront before you treat patients. And this effect, 60 months is quite a long time, right? And so we think we're doing an intervention, things will kind of normalize by the 60-month mark, but not so much here. So what increased your likelihood of developing kind of a more concerning amount of hypogammaglobulinemia? What they identified was that those who were female or those who had been treated with cyclophosphamide prior to Ritux were less likely to be able to kind of mount a resurgence of their immunoglobulin levels. And then if they were still on prednisone at 12 months, again, they struggled to remount their immunoglobulins back to normal or to a higher category. In the same paper, This was really interesting. They actually did not find a difference in terms of infection rate between mild, moderate, and severe hypogammaglobulinemia, whether they looked at infections or severe infections. With that being said, though, the severe folks, even in the absence of symptomatic of like infections and things like that, often tended to get IVIG replacement, kind of to a proportion of almost 60%. And a lot of these patients got placed on antibiotic prophylaxis as well. And then here, what we're seeing is of the patients who ended up receiving IVIG, you see a statistical improvement in terms of infection risk over time, but not a statistical improvement in severe infections. Severe infections being hospitalized patients requiring IV antibiotics. And so the N for this is very small. I mean, you can see there 19.9, one patient who received IVIG. But it's interesting that it doesn't seem like IVIG made a significant difference in terms of severe infections, which is contrary to what I would have thought. Again, limited by the end of this paper. So ultimately, our patient ends up being gets immunology consulted and on board. Immunology attributes the hypogammaglobulinemia actually to the protein losses, right? This patient had 10 grams of proteinuria. Immunology felt like the reason that this patient was so severely hypogammaglobulinemic was from the protein loss rather than the cryo or alternate issues. They were worried about the patient who was already severely hypogammaglobulinemic, having to get on rituximab, having further immunoglobulin depletion. They felt like they were going to be at too high a risk of infection, so they went ahead and recommended IVIG. So this paper, I think we all kind of have it, just a Ritux and Maveret. Yeah. I think my understanding is for cryo, the primary mode of treatment, especially for Hep C related, is going to be rituximab to kind of decrease immune complex production and treatment of the hepatitis C. I think, should things have changed because we saw the immunoglobulin levels? I think that's a question to have. But for this patient, decisions was made move forward just with rituximab and treatment of the Hep C. So we all kind of have an intuitive understanding that in nephrotic conditions, you have lower immunoglobulin. This paper is really interesting. It's from the 70s. It shows here minimal changes these patients. Their mean percent serum IgG is 20% that of their age-matched cohort. So they're losing quite a bit of immunoglobulin, right? And what's interesting is when they get treated, their immunoglobulin levels increase pretty significantly right thereafter, right? So we at least have a pretty close association here. The more nephrotic you are, the more likely you are to be hypogammaglobulinemic, which in turn may increase your infection risk, etc. So per the KDIGO glomerular disease guidelines, they admit that there's not great data for this, not like a comparative RCT, but they do make the recommendation of checking immunoglobulin levels prior to initiating and then every 6 months, right? And again, the thought is if they start off really low, you should be thinking about giving them some replacement early because they're likely to stay low or get lower, and they may have kind of a prohibitive risk of infection at that point. So our patient ended up receiving IVIG. Ritux is completing Maveret, is doing pretty well. So I'll leave you guys with this. MPGN is not a diagnosis, a pattern of injury. Your immunofluorescence is going to help you determine kind of what why the MPGN is there present and allow you to make a diagnosis. Most commonly, what we're dealing with, guys, in terms of MPGN is going to be autoimmune conditions, infections, and paraproteinemias. Untreated Hep C is going to be the most common cause of cryos that we're seeing right now. Maybe for our room colleagues, the lupus overlap. And then really, I'm trying to make a pitch for all of us in nephrology to maybe start checking immunoglobulins up front before initiating rituximab and then monitoring that over time. So sorry, we're a little bit over time, but any questions or comments? Yeah. So I think the thought behind the question is IVIG contraindication in cryo. I think in a patient who's not hypogammaglobulinemic as treatment for cryo, that would be contraindicated. In a patient like this, I don't think that you're significantly increasing the risk of thrombosis or things like that. So I think it's a different patient population there.